Awesome. Thank you, Ryan. Good afternoon, everybody, and welcome to today's webinar, our next session of the Nurture Me monthly webinar series, Methadone During Pregnancy and Postpartum, featuring Dr. Elaine O'Connor. My name is Hannah Winkelhofer, and I am the ACE and SEI Prevention Coordinator with the Maine CDC. Before we introduce Dr. O'Connor, a little housekeeping. Today, we're using Zoom's webinar format, which focuses on the presenter. However, you're encouraged to share questions with Dr. O'Connor to answer in the Q&A section, which I will be monitoring throughout the webinar. If you have any technical questions or would like to add to the conversation, please direct your comments into the general chat section. Near the conclusion of the webinar, Ryan Nealon from AdCare will share an evaluation link for today's presentation. We really appreciate you taking a moment to provide your valued feedback, which helps ensure that we are providing quality content. Also, Ryan will be sure to email your participation certificate within 10 business days. And now it is my pleasure to introduce our presenter. Dr. Elaine O'Connor is the Director of Perinatal Addiction Medicine at Maine Medical Center and is the medical advisor of the Maine Maternal Opioid Misuse Initiative, a 5-year, $5 million federal grant to expand access to substance use disorder treatment for pregnant and postpartum individuals in Maine. Dr. O'Connor also co-chairs Maine's Opioid Response Clinical Advisory Committee, which advises the Governor's Opioid Response Director on clinical and public policy issues. She has more than 15 years of experience in addiction medicine in a variety of settings, including the design and implementation of an extended release buprenorphine pilot at Somerset County Jail, rapid access to substance use disorder treatment in emergency departments through Maine Medical Association's Project RISE, as well as extensive experience caring for pregnant patients with substance use disorder in both the inpatient and outpatient settings. Dr. O'Connor lectures regionally and nationally and has trained more than 100 family medicine and obstetric resident physicians. She is a core faculty member of Maine's only addiction medicine fellowship program. And finally, Dr. O'Connor has published numerous peer-reviewed articles on maternal and infant outcomes following substance-affected pregnancies, including child welfare implications, as well as the care of pregnant patients with substance use disorder who are incarcerated. So please help me in welcoming Dr. O'Connor.
Good afternoon, everybody. I'm really excited to be here. I see there's almost 100 folks listening in, so that is exciting. I'm just going to bring up my slides. I'm really happy to be here with you today. Slides are up. Somebody signal me. Yes?
Yes.
Please? Yes, perfect. Thank you. So we're going to talk about methadone during pregnancy and postpartum. As Hannah mentioned, this is one of my loves, working with pregnant folks with substance use disorder. It's important to note that I care for a tremendous number of pregnant patients with substance use disorder, but I myself can't provide methadone in the outpatient setting. So I think sort of the overlay of this is that, this can be a challenging issue for patients because of the limitations in access to methadone through opioid treatment programs. So we're going to talk a little bit about some of those challenges, talk about the medication, talk about issues pertaining to substance use and pregnancy in general, to sort of try to give you this sort of 360-degree view. So we're going to talk about evidence-based best practices for screening for substance use disorder in pregnancy and strategies for really talking about substance use in pregnancy. It can be a tough topic. And so I'm going to give you some sort of pearls, clinical pearls. We're going to talk about the initiation and dosing of methadone during pregnancy. So really important to know what is different and not different during pregnancy as it pertains to methadone. Talk a little bit about maternal and infant outcomes associated with methadone exposure in pregnancy. And then talk a little bit about some of the specific issues for pregnant patients with opioid use disorder, such as delivery planning, pain management, breastfeeding, hepatitis C, among others. I did leave plenty of time at the end for questions. So if you have questions, feel free to put those in the Q&A box, which is somewhere on the screen. Okay, so substance use disorder in pregnancy. So reviewing some basic concepts here. Oops, my slides just went away, sorry. Evidence-based verbal screening is the standard of care. So there's oftentimes a lot of questions around, oh my goodness, I'm sorry. A lot of questions around how should I screen for substance use disorder in pregnancy? And verbal screening is absolutely the standard of care. The 4 Ps is a screening instrument that is used fairly frequently. It's a pretty easy questionnaire to use. Sometimes if that screen's positive, you need to sort of ask additional questions or use an additional screening instrument. It's important to note that universal urine toxicology testing is not recommended for screening. So it's really important I highlight the word screening there, because we often do toxicology testing for pregnant patients with substance use disorder, but as a screening test, it's not recommended for a whole host of reasons. The most common one is that people are often not consented to it. It's sort of just done as a kind of an add-on test, which is definitely not recommended. There's a lot of limitations with toxicology testing, specifically around how long substances stay in the system. And so it's not recommended as a screening instrument. Pregnant women are often highly motivated to engage in treatment, but they're simultaneously really fearful about disclosing substance use. So this is a very common clinical picture. Patients are unexpectedly pregnant because 80% plus pregnancies in folks with substance use disorders are unplanned. And there's sort of this, oh my gosh, what do? I want to get help. If I get help, am I going to get reported to child welfare? How do I even find help? People often are, very stigmatizing and shaming toward these patients. They'll have family members say, if you really loved your baby, you would stop using drugs entirely. They get a lot of very negative messaging and a lot of guilt and shame. And so there's kind of this helpless feeling. And as such, I think you see a lot of delayed access to care because I think people are sort of not sure what to do and kind of don't even know where to begin. So that's been really one of the values of Maine Mom. So the standard of care for treatment of opiate use disorder during pregnancy is medications for opiate use disorder, or MOUD. Methadone has been around a lot longer than buprenorphine. So we started using methadone in pregnancy in really the 1970s versus the 2000s for buprenorphine. So when I first started working clinically in this line of work, that was 2006, 7. So it was probably a stronger argument to use methadone at that point because we really didn't have a lot of data around the use of buprenorphine in pregnancy. That certainly changed now. So I think both are really great options. And I think it's really shared decision making with your patient as to which is the better option for her during her pregnancy. Education and support of patients with SUD or OUD during pregnancy is critical. There's usually a lot of other issues present. As my team at Maine Medical Center can tell you, a lot of social determinants of health needs, clothing, housing, food. I saw a patient when I was out last week with the fire department living in a hotel. I have patients who live in tents. And so there's usually a lot of issues present. Co-occurring mental health diagnoses are also very common, uncertainty and fear around what medications to be on or not be on. And they've experienced a significant amount of trauma or intimate partner violence. If you look at the ACEs or adverse childhood experiences that my patients have experienced, it's often very high. And there does seem to be almost a linear relationship between the number of adverse childhood experiences they've had and their risk of developing a substance use disorder. So patients will usually come in and say, well, I don't want, why do I even need to be on a medication? I just want to stop using everything. I just want to stop it all. And you can certainly understand the motivation behind that. I think, they're trying to do the right thing for their pregnancy, for their baby. But it's really not a very effective approach as it pertains to opioids in particular. Certainly, it's very difficult to stop cold turkey, as we know in working with folks in the community. And it's very clear that if we get them connected to treatment medications, they're more likely to obtain prenatal care, more likely to avoid high-risk behaviors, sexual behaviors, legal behaviors, returns to use. Because if they stop using, fentanyl on the street, they're going to experience a very severe withdrawal. And, they're going to need to use something else to be able to sort of curb that withdrawal and those cravings. And so it's not really an option to stop using everything, particularly as it pertains to opioids. And so just kind of talking people through that the best option is to be on a medication. The best dose is really the dose where the patient has no cravings or withdrawal. There's a lot of confusion about that piece, but just working with your patients to understand the role of medications and that's really a mechanism for them to get connected to the other services that they need. So prenatal care, substance use disorder treatment, all the other things that a pregnant patient would need. Okay, so this is a table I put together, kind of how I think about the two primary medications that we use during pregnancy. We sometimes also do use naltrexone. I didn't put a lot about that in here. It's not commonly used for opioid use disorder in pregnancy, but it's quite commonly used in alcohol use disorder. So methadone and buprenorphine, both first-line treatment during pregnancy, both great options. And you can use either the monotherapy, formerly known as Subutex, or the combination therapy Suboxone during pregnancy. Both are perfectly fine, perfectly safe. I usually let the patient decide which they're more comfortable with during pregnancy. And then I do use the combo therapy postpartum, or sometimes we use the injectable. Don't use that as much during pregnancy, but I do certainly use it some. So all are good options during pregnancy. So methadone is much easier to initiate. So from a chemical compound property perspective, methadone and fentanyl, which is really all we see on the street now. We don't really see any of sort of the traditional heroin from the poppy plant. They're similar from a sort of chemical properties perspective in the sense that they're both what we call full agonists. So they sort of bind to the same receptors and activate them over time. It doesn't mean that people who are on methadone, I always want to be clear to say that doesn't mean that they're abusing it, misusing it, or becoming high in any way. It's just that they're a similar medication from a chemical properties perspective. So they're both full agonists. So the really nice thing is patients don't have to be in withdrawal or endure a prolonged initiation with methadone. So you can basically sort of have people come off the fentanyl and then sort of escalate up the dose of the methadone, and patients don't typically have any kind of withdrawal. They feel better usually pretty quickly. Sometimes you have to do the dosing pretty aggressively because of the potency of the fentanyl that we see. The only challenge there is that methadone can only be initiated inpatient. So we can do it in the inpatient unit, which I'm going to talk a little bit about, or at a licensed outpatient treatment program. So what you typically would call a methadone clinic. So it could be Discovery House, it could be HCRC, actually Discovery House is CTC now, it could be CAP, could be Everest. There's a lot of different options. They're not very geographically diverse, though. That's another thing to be aware of, that, we have many in the Portland area, and there's certainly far fewer in other parts of the state. So it's easier to initiate from the perspective of the medication itself, but challenging in some ways in terms of where you can access it. So buprenorphine is a lot harder to initiate, again, because of this risk of precipitated withdrawal, because it's different. It's a partial agonist to the opioid receptor as opposed to a full agonist. There's a lot of norfentanyl that sits in the system, and when people are using fentanyl, and that can sort of compete with the buprenorphine when you start it. And so you sometimes do this low dose microdosing initiation, which takes a lot of time. It can take like 7 to 10 days. And you kind of just slowly increase the dose of the buprenorphine while the patient is actually continuing to use fentanyl, which is also sometimes stressful for patients, stressful for everybody. But if you go too fast, there's that risk of precipitated withdrawal. So the upside of buprenorphine initiation is it can be done in many more locations. You can do it on the inpatient unit, the outpatient unit. You can do it at OTPs. They also typically offer Suboxone, but it can be harder to actually do from a medical perspective. So there's sort of pros and cons on both ends. So as it pertains to methadone, some studies show treatment retention is improved due to those pharmacologic properties. So in other words, because it's easier to start folks on it, people tend to stay on it. It might work better for folks. But daily trips to the clinic can be insurmountable. So I always say the number one reason my patients fail methadone is because they can't get there. And childcare is often a challenge. They might have to bring their kiddos with them. And so it can be difficult for folks to continue to access it. It often takes time for patients to be eligible for take homes. And then again, some studies show buprenorphine treatment retention is better because it's easier to access. With methadone, as the potency of the fentanyl continues to increase. So as we're seeing the fentanyl on the street increase in potency, it is probably easier to control withdrawal symptoms and craving with methadone than it is with buprenorphine, for sure. So prior to the extended release buprenorphine or the injectable option, I really sometimes would sort of max people out on their sublingual buprenorphine, and I really just couldn't control their symptoms adequately with buprenorphine. So those are folks that had to really transition to the methadone clinic to really kind of quote unquote meet their opioid requirement, because buprenorphine does have this ceiling effect. So when you dissolve it sublingually under the tongue, there's sort of only so much that you can actually absorb over time. And so sometimes that just wasn't enough for folks when they were using a lot of opioids. And certainly, again, as the potency has increased, that's become even more challenging. So buprenorphine exposed newborns do seem to do a little bit better in terms of they have longer gestational pregnancies. They are a little bit higher birth weight, larger head circumference, and seem to have a less severe withdrawal syndrome compared to methadone exposed newborns. So that's something to be aware of. It's probably just because of the different chemical properties. Methadone does have a higher potential for respiratory depression and overdose. So again, if you continue to increase the dose of methadone and that was used concurrently with fentanyl, there is that sort of risk of kind of them working together in an unhelpful way. So there's the sort of higher risk of opioid depression and overdose. As I mentioned, buprenorphine has this partial agonist effect, so it's probably a little bit protective. But at the same time, if their symptoms are not well controlled, are they more likely to have a return to use? So again, this is sort of there's pros and cons on both sides. And I think the best option is to make sure your patient understands all the options or both of the options. And then you really kind of engage in a shared decision-making process. And you can start one and sometimes move back and forth if you need to. It can be hard to go back and forth. As I mentioned, certainly starting a buprenorphine, a partial agonist is harder. But sometimes I have seen a few cases where patients have come to me on fentanyl and then they've gone to methadone and then it's been hard to get to, or they decided not to do that. And it's actually easier to transition folks from methadone to buprenorphine than from fentanyl to buprenorphine. So sometimes people have kind of done a sort of multi-step process, but it's difficult all around. So starting methadone in the inpatient setting is absolutely something you can do. This is from the Bridge program, which for those of you that aren't familiar with the California Bridge, it's a wonderful resource for all things opioid related. So, and actually other substances as well. So I really encourage people, it's an active link, you can click on it. I really encourage folks to go to this website. This is a nice, easy algorithm. They have a ton of really easy algorithms to kind of follow. So this is how they recommend starting methadone in the inpatient unit. It's pretty straightforward to some extent. The biggest challenge often is that you can't, so if I'm discharging a patient from the inpatient unit, I can't send them home with a methadone prescription. So you really have to sort of tightly connect them. Usually they get the dose in the morning before they leave, and then they have to go to the clinic the next day. So there is that sort of required really tight connection, which can be challenging if it's a weekend or a holiday or something like that. So that's the only thing to be aware of. You're not allowed to do like a bridge script like you might do with buprenorphine. So dosing of methadone during pregnancy is really important. This is, I think, fairly kind of not well understood. And this is true as it pertains to buprenorphine, but I think even more true with methadone. So doses may require adjustments during pregnancy. And it's super critical to normalize this for patients. I say this to folks all the time, like, hey, as your pregnancy progresses, you may not feel like your medication works as well. And that's normal, so don't hesitate to speak up and just let me know, because patients will sometimes perceive that they're doing something wrong. They'll think, oh, I don't want to tell her I'm having more cravings or withdrawal symptoms. And so I really encourage people to speak up that that's a normal finding. It doesn't happen for everybody, but it happens for most people. And I used to think it was like only second trimester, but I do find that sometimes it can really occur anytime, in part because sometimes you're like still stabilizing somebody in their second trimester. Sometimes people find that it really changes. Like when I've had patients come in many times and say, I feel like I popped. And like at the same time, I really felt like my methadone wasn't working as well. So it can just happen anytime, and they're not doing anything wrong. So methadone metabolizes through the CYP450 system, just a pathway in the liver in which it's metabolized. And that pathway is actually what we call induced or like sped up by elevations in progesterone and estrogen, which occurred during pregnancy. So those are common hormones that change pretty dramatically during pregnancy, and that actually causes that system that metabolizes the methadone to speed up. The conversion of methadone to its inactive metabolite, so it's a really long word, but most of us call it EDDP, is accelerated in the first trimester, with actually an even more rapid acceleration in the second and third trimester. And some studies show that the half-life of methadone later in pregnancy has actually been reduced by half. So it's a pretty dramatic change. There's no specific dosing regimen. I looked in the literature a bunch of different places, and there's no specific dosing regimen that says that's been established, but it does appear that patients are more likely to be retained in treatment and actually less likely to use illicit substances if the methadone doses are increased in kind of a linear fashion during gestation. So what I mean by that is like the dose goes up as each week of the pregnancy goes up. But there isn't like a very specific, like, 5 milligrams a week or 2 milligrams a week or anything like that. But it does seem that there's this sort of steady linear increase, does reduce the risk of illicit substance use, and also increases the risk of being retained, or increases the likelihood of being retained in treatment. So this is another really important concept. So split or more daily dosing. So because these pregnant patients undergo a metabolic shift toward ultra rapid metabolism, which lowers their serum level of methadone. The single daily dosing protocols likely cause the mom and the fetus to experience daily episodes of withdrawal. So most people who go to the methadone clinic receive one dose a day. They typically will go back every day and get that same dose. There are take homes that are available at some point, depending on their stability, depending on their engagement. Do they go to counseling? What does their urines look like? But most people do a single daily dose. In pregnancy, managing that with the withdrawal sort of solely by increasing the single daily dose exposes the mom to sort of higher peak levels than you really want, which might come with oversedation. So say if you have a mom who starts at 100 milligrams of methadone, she increases over the course of, a month or two to, or three to like say 130, 150. If you just increase that first dose, what happens is that basically she sort of too much medication for right after she takes the medication, and then there's this dip later because she's metabolizing it quicker. So she's actually having a period where she might be even over sedated, where later in the day doesn't feel like she has enough. So while increasing the overall daily dose is important, like I talked about with that kind of linear in a linear fashion, it's really dividing the dose that the serum levels can be maintained in a safe and effective stable range. So this is super common for patients to come in and say, I literally was just having this conversation with a patient yesterday, and I've been talking to her about it for the last couple of weeks. And she's saying, they keep increasing my dose. I'm up to 110 or whatever it was that she was at. But she's like, I don't feel good later in the day. I take the dose in the morning. I feel okay for, 4 or 5 hours. And then by the end of the day, I really don't feel good again. And so I've been encouraging her to sort of talk to her provider about this at the methadone clinic. And I'll talk a little bit more about that. So the challenge is that it's a challenge to increase or to split the daily dose. And so it requires a request to the state opioid treatment authority. The federal requirement to do that was actually removed, but that, as I understand, still does exist in Maine. It requires knowledgeable regulators on why this exemption is specifically legitimate. In other words, if they're concerned about split daily dosing, it really should be, in my opinion, the standard of care during pregnancy. It also requires a medical provider who's familiar enough with regulations to request and provides justification for this exception. And then a program administrative structure that doesn't deter requesting exceptions. So I'll talk to you a little bit about the patient I was talking about yesterday. I've been seeing her every week for the last several weeks. And she was, really doesn't seem to be doing well with, just this increase. And I've said, hey, you talk to your providers. And it's not a clinic that I work with a lot. I'm pretty tight with the medical director of a couple of the other clinics. So I keep, they know me and sort of how I recommend doing this or what works best for pregnant patients. So I actually called over the clinic yesterday and said, hey, I really want to talk to somebody about increasing this person's dose, like in terms of split daily dosing. And unfortunately, the person I got on the phone didn't, even though I clicked the sort of nursing box, didn't really know what I was talking about. And I said, okay, well, can you have somebody call me back? And she said, yes, absolutely, within an hour. And I'm still waiting for the phone call back. So it's a challenge. And I think it's not something that a lot of programs are necessarily familiar with if they're not working with a lot of pregnant patients. So I think if you're the provider out there who's working with the pregnant patient, particularly from the OB perspective, just an awareness of this issue. And again, kind of encouraging people to talk to their providers. And then even you yourself potentially reaching out if the patient is not having any luck. And hopefully that this particular case is to be continued, but hopefully I'm able to eventually get us there. Oh dear. Sorry. Are we back sharing? I'm sorry. I don't know what just happened there. Is this sharing again?
It is. It is.
Okay.
Being,
I'm not sure what happened. Is that, there we go. I'm sorry about that. I'm not sure which button I pressed, but obviously not the right one. Okay. So another question I get a lot is, what about the prolonged QTC? So what is the QTC? So the QTC interval is basically how long it takes for after the heart beats from sort of the top to the bottom of the heart. Your heart kind of repolarizes or kind of resets itself after each beat. And what can happen sometimes is like that repolarization can actually be delayed. And that is a real thing with methadone that can cause that potential effect. So there's all kinds of questions about, like, do you need to do an EKG? When should you do an EKG? How many EKGs should you do? And so there's actually limited evidence of the utility of a baseline EKG. So I see this a lot. And again, this might be in an inpatient setting where people are saying, oh no, which med should I start? How should I start it? and I need to get an EKG before I start it. And there's actually little evidence to suggest that that's necessary. Studies on the relationship between methadone dose and the degree of sort of that prolongation of that interval has had conflicting results. And again, when that gets really delayed, what can happen is sort of the electrical activity in the heart can basically go haywire, for lack of a better way to put it, and that can cause cardiac arrest. I have seen that happen once in a patient with on methadone, and unfortunately, she had to come off the methadone. This happened to her before I was taking care of her, but then she became pregnant, and then we really put her on buprenorphine because it wasn't. A bunch of doctors kind of weighed in on it and felt that it was very much related to the methadone. She struggled honestly on buprenorphine, but it really wasn't safe. But that's an unusual situation. And the belief really within the literature and I think common practice is that in the age of fentanyl, initiation of methadone and dose increases should not be delayed if you can't get an EKG and they're clinically indicated. Because in our world, with the fentanyl as potent as it is, the risk of just continuing to use fentanyl is so high, and so you don't want to, anything that sort of drives people to go back to using fentanyl is probably the most dangerous approach. But it is true that high doses of methadone can be prolongating. In other words, that QTC interval, like you see up in the upper right corner, can be delayed. And EKG screening is advised for patients who are on doses above 150 milligrams, or who have some other risk factors, an increased risk for arrhythmias, like those with endocarditis, which is an infection of the heart that we sometimes see as a result of substance use disorder, previous history of a ventricular arrhythmia. And the other big one I think to be aware of is folks who are taking other medications that can prolong the QTC interval. So you may not see that many people on antiarrhythmics like amiodarone, but you do see people certainly on antibiotics. So there's certain antibiotics you probably should select against if you're have someone on methadone, or certain antidepressants as well, some antipsychotics. So just an awareness, if you get that thing that pops up on your screen, I feel like we get so many of those when you're prescribing stuff. But if it says, hey, risk of QTC prolongation, or you look it up and, it's probably best to choose a medication that doesn't have an added risk. So sometimes we'll see in the hospital a slight delay in the QTC, and, sometimes they'll take off an antidepressant, try a different one. And so just an awareness that that's an issue. But again, shared decision-making with the patient, risk versus benefit, having that conversation, changing the medications that could be worsening the situation. And then, if you have to, you could consider moving to buprenorphine, and that's something that you should at least consider. Infants born exposed to opioids are at risk for withdrawal. So you sometimes hear the term NAS, or neonatal abstinence syndrome, but what we're probably using more frequently now is neonatal opioid withdrawal syndrome, or NOWS. A lot of the literature still says NAS, but NOWS is used somewhat interchangeably. So those are central nervous system hyperactivity, autonomic system dysfunction. So sometimes you'll see kind of irritable sort of infants that are kind of have very tight muscles and sort of are kind of jar easily and are a bit more irritable potentially. Sometimes they have GI dysfunction. Typically, they begin sort of 24 to 72 hours after birth. So, when the baby's born, the baby's metabolizing out whatever opioid they were exposed to. And so that takes time. And sometimes there are symptoms associated with that. Patients are often very nervous, and that's, again, the desire sometimes to hold their dose down. They may say, I don't want to increase my dose even if I need to, because I don't want I'm using quotes, whenever I use quotes, these are their words, I don't want my baby to suffer more. And we have that conversation like, hey, you need to be on the right dose for you. There's no relationship between your baby's withdrawal and your dose. So whatever dose makes you feel the most comfortable, you don't have symptoms, you're not having returns to use, that's the best dose for you. Infants do remain in the hospital for at least 5 days after birth to be monitored for the withdrawal. Eat, Sleep, Console is probably the tool we use much more frequently now. I think most of the hospitals in the state use that. Rather than the Finnegan scoring system, which is what we use for probably the first decade of my practice. It's a much more patient-friendly approach. It's much more, includes the parent much more. There's less emphasis on numbers. That used to be a huge issue for my patients. Like, if someone came in and scored their baby a 4 versus an 8 versus a 12, there was just a lot of anxiety around that. And there was also a lot of variability amongst the raters. So you might have somebody who came in who scored an infant at 4, and somebody else could score the exact same infant at 8, in part because some of the symptoms are hard to, there's, sneezing and some amount of irritability is normal. And so it can be hard sometimes to figure out exactly what was causing what. So Eat Sleep Console is really simple. It's just a measure of like, are babies eating okay? Are they sleeping okay? And are they consolable within a certain period of time? And if that's not the case, there's interventions that happen, but it's typically, medication is kind of a much later step. So it's things like low stimulation, low light environments, a lot of skin to skin contact, swaddling the baby. So they're able to do a lot of stuff up front to reduce some of those symptoms. And if they do require a medication, it's typically an opioid, could be morphine, could be methadone, could be something else. But it's typically dosed like PRN. And again, like 20 years ago when I first started doing this, we tended to start babies on methadone, and it lasted for a month or months, even sometimes many months. Now we see that far less frequently. So people are kind of dosed as needed, the infants. And so they might get one dose of morphine and they might get another one 3 or 4 days later, but it tends to not be kind of starting on an opioid and lasting forever. So much better experience all around for the infants, I think, for the parents, for the whole sort of system. So there was a nice meta-analysis that I looked at that concluded that the incidence or duration of NAS does not differ based on maternal dose of methadone. So again, that's a really important point for your patients. So please, attempts to minimize methadone dose are not indicated, as low doses are not consistently associated with milder or shorter NAS. And in fact, some studies have found that actually there's lower rates of NAS when methadone doses are split. So that makes perfect sense, right? If the mom is feeling better during the day, kind of her serum level is more consistent. That's what the baby's experiencing too. It's not this kind of up and down during gestation. So we talk a lot about rooming in, what this looks like. Patients will always say, hey, am I going to be separated from my baby? Where do they go? And we have conversations about kind of, because sometimes things happen during delivery that are totally unrelated, certainly to the methadone. So there may be a reason patients have to go to the NICU or something else, but we talk about the fact that, from a strict sort of opioid exposure perspective, 5-day hospital stay, rooming in if there's nothing else going on, what it looks like. And sometimes it's helpful to tour the L&D unit. If that's useful, we certainly recommend that. So Maine has a substance exposed infant notification, also important to talk to your patients about. This is potentially changing. There's a lot of different legislation about this right now. There's a couple different bills in the legislature. A lot of conversation about this. How do we do it? How do we do it differently than other states? Do we do it the right way? I'm glad we're talking about it. I think it's really important to be talking about it. Half of all child removals in Maine do involve substance use. So this is a real issue for parents. And Maine does have a mandated substance exposed infant notification. So it's technically not a report of child abuse or neglect. So it's a notification that the infant was substance exposed. The reality is, because both types of reports go to the same phone number or Office of Child and Family Services, patients don't really interpret it as very different, even though it is sort of two different things, a notification versus a report of abuse or neglect. But patients, again, don't experience that. So I think there's ways in which we can improve the process so patients can better understand what's required by the federal CAPTA, Child Abuse Prevention and Treatment Act, because there are certain federal requirements of reporting your substance exposed infants, but what is required by that versus how are we doing it from a risk of harm or to the child's safety. And I think those are different things. But it's important. This is the elephant in the room, as I always say. Like, you need to discuss this early and often and be honest. I actually have this conversation at the very first visit with patients, and then I talk about it throughout their pregnancy and try to really tell patients that this is what to expect. This is what the process looks like. These are the social workers on the inpatient unit who do the reporting. Sometimes we've had the social workers actually come meet the patient beforehand, if that's helpful to them, what it looks like for the OCFS workers that might come to the hospital. One of the other issues that you have to at least be aware of is if you have somebody who is coming in because they're pregnant to seek treatment, but there might be other little kiddos in the home, say a 2-year-old in addition to the pregnancy, and what's going on at home. Are you concerned about the safety and well-being of the 2-year-old? I always have that conversation very openly with my patients. I'm really clear that, like, if I report you or if I feel that you needed to be reported, I will talk to you about that. I will tell you exactly what I said, because I feel like they're entitled to the information that I would provide and what I would be doing. And patients uniformly are just incredibly grateful that they know what's happening. so that they're just aware of what I'm going to be doing, that I talk about it openly. It actually creates a much more therapeutic relationship. So this is the SEI notification law or regulations as it exists right now. So I kind of highlighted the particular issues that I sort of try to focus on when I'm talking with patients. So a healthcare provider who's involved in the delivery has to, notify about an infant affected by substance use, who has a withdrawal symptoms that require some type of medical monitoring or care beyond the standard of care, and whether that was to legal or illegal drugs. And so this is, again, one of the elephants in the room is that as it's written right now, people who are on any form of MOUD, well, who are on either buprenorphine or methadone, not necessarily naltrexone, but that's kind of beyond the scope of this. But everybody has to be reported to OCFS. So it's a challenge. I think there's definitely room for improvement on that, because I think folks know, I think in the community that you probably will be quote unquote reported. And again, it's a notification, but that's not necessarily how they see it. And so I think there's definitely room for improvement from my personal perspective on people that are in treatment, who are doing well. If you don't have any other concerns, why are we reporting them? I don't know. But there's a lot of conversation, a lot of work groups. I think my perspective is a lot of interest at the state to sort of have this reflect best practice. And so that's an ongoing, I was literally on a call about this yesterday and on another call about it next week, but there's a lot of effort right now with various pieces of legislation. So collaborating with OCFS, notification, plan of safe care is really typically very helpful. I mean, I think there's been issues sometimes that have come up around release of information confusion. So maybe OCFS somehow gets the message like patient didn't sign a release when in fact they did, but it got lost or the date was wrong or something else. So it can be very helpful to kind of collaborate on that front. It can also be the case that patients can't necessarily come in with their own lab results. They have to be certified. That's really true, I think, with methadone clinic. But the hard part is the reality. I mean, I struggle with this, and this is a conversation I have with the state all the time, is that if people are in treatment, to some extent, we're providing evidence of substance use because they're probably testing positive sometimes. And how do we need to treat people who are in pregnancy, or excuse me, who are in treatment during pregnancy as in the treatment engagement needs to be considered as this sort of child welfare piece comes into it, that we cannot somehow encourage people not to get connected to treatment and have them sort of have an easier time. That people who are in treatment, who are engaged, who are coming in, who are seeking prenatal care, who are following the recommendations of their treatment providers, even if they're having the occasional return to use, we can't somehow punish that because it's in their record. And I think it's important for it not to be punitive to begin with, but I think that's there's some conflict there right now. I don't think we've perfectly solved that issue, but so I just want to raise that for folks who are on the call. Infant outcomes following methadone in pregnancy. So now it's occurred in 52% of infants exposed to buprenorphine compared to 69% of those on methadone. Preterm birth was higher for those on methadone, and small for gestational age as well as low birth weight, probably all connected to some extent. And so that's just sort of what the literature shows. But again, the medication that's right for the patient is the one that she should be on. There does seem to be some evidence of maybe some neurodevelopmental disorders, again, a little bit higher in folks on methadone than on buprenorphine. Hard to say to what extent this is significant. There's no clear evidence of any kind of congenital abnormalities, although there is some evidence to suggest maybe there's some ocular disorders that we may be seeing more folks who are on opioids during pregnancy. But again, hard to say one over the other. The most important thing is to be in treatment. Maternal outcomes, the risk of delivery by cesarean section is similar in the two groups. Rates of severe maternal complications are also similar in both the groups and quite low. I feel like the complications we see during pregnancy are largely related to folks who are not in treatment, to be honest, who are continuing to use fentanyl, or really some of the complications that we see around stimulant exposure during pregnancy, so methamphetamine or cocaine. There are not good treatment options for those necessarily from a medication perspective, so people really struggle with that. So the most common complications I really see are sort of outside of the MOUD component of things. So why are there differences in outcomes, particularly on the infant side of things? It's probably the pharmacologic mechanism of action. So the partial agonist versus the full agonist, it's, stronger medication to some extent, and that's how you can sort of think about it. It has been suggested in the literature that the more favorable outcomes in buprenorphine are because the infants are born infants are born to folks who are on buprenorphine, which means they have a less severe OUD. That it's not really supported by the literature, but there's sort of this ongoing question, but it doesn't seem like, so there was, some people think that like, oh, if their OUD is not as severe, they're going to be on buprenorphine. And if it's more severe, they're going to be on methadone. But the literature really doesn't support that. So it's probably mostly related to the difference in the mechanism of action. So what does this all mean? Again, the best medication is the one that's best for the patient, and shared decision-making is essential. So it's more than just the medication. It's how are you going to get there? Are you able to get to the clinic every day? Is there a clinic that's near you? I mean, I had a patient not too long ago in the inpatient unit who started on methadone, and the nearest methadone clinic to her where she was going home to is an hour and a half away. And I just was like, I don't think that's realistic. I don't think she's going to be able to do 3 hours a day in the car. I just don't, if she even has a car, or she can get, transportation, because it's not a perfect science. And so the reality is, if the closest methadone clinic is an hour and a half away, that's probably not an option that's going to be workable. So it's a matter of sort of access and medication, what's worked well for people in the past, all kinds of questions. And I think it's really shared decision-making with your patient. Is she specific to opioid use disorder and pregnancy? So there's this ongoing question of how prenatal care should be adjusted in pregnancies impacted by OUD. Lots of times people start doing monthly ultrasounds at 20 to 24 weeks. It's important to know that methadone, because of the way it works, can cause decreased heart rate variability and fewer accelerations in the fetus, which of course, those are things we like to see. So it's best to delay the test 4 to 6 hours after methadone consumed if possible. Certainly best not to go right from the clinic to a test if you can avoid it. There's a lot of common complications in patients with opiate use disorder who are pregnant, the most common of which is that both pregnancy and opioids can make you constipated. So I have several patients yesterday just like managing aggressively constipation and nausea because it's so common. And, again, it's not something people necessarily want to bring up. Like, I'm not, having bowel movements. Like, so it's important to ask the question. I think particularly with the nausea, oftentimes it's like they're having bowel movements like once a week. And so sometimes when you get that constipation under better control, the nausea actually goes away. There's a marked increase in hepatitis C infection amongst pregnant patients with opiate use disorder. It's as high as 50% in some populations. Critical to screen. So it's actually universal screening is recommended for all pregnant patients. Education is super important, and patients are very fearful. There's a lot of confusion about like if there's an antibody positive, like, because again, people who've had hepatitis C and had it treated, or some people who've had hepatitis C and then sort of processed it through, kind of cured it on their own, will still always have that antibody. Sometimes people will tell them that they have hepatitis C if they just have this antibody. So it's important to sort of know what is and is not hepatitis C amongst people with substance use disorder, because it can be very confusing. So if people have the virus present, like the RNA, kind of what are the numbers? I don't place a lot of stock in like what the numbers are. People say like, oh, should you do more testing to get the numbers closer to delivery if mom has hep C? I don't see the value in that, because in the end, you want to screen the infants anyway. The vertical transmission rate, so the risk of mom sort of giving it to the fetus, is only about 5 to 7%. The most important thing is just to make sure that the pediatric providers who are caring for the infant to be aware of this maternal hepatitis C exposure. We don't treat hepatitis C during pregnancy or during breastfeeding, but we treat it after. Most substance use disorder treatment providers do it now. It's really easy to do. I do it all the time. It makes people feel better. Like they're like, hey, I'm leaving that part of my substance use disorder kind of in the rear view. Super easy to do, and it's like one of the most effective things that you do. Like, it's really, I enjoy treating it because it's literally that easy, and it's incredibly effective in the way that 15 years ago it didn't necessarily always work. Now it really always works. The method of delivery doesn't change. People ask that question: oh, do I have to have a C-section? Or and no, nothing changes. So again, treatment is important to refer to or do yourself. Most patients require IV access during delivery. This can be super triggering, so trying to make sure that patients are aware of this can be shaming. It feels terrible when somebody has to draw your blood 3, 4, 5 times, or try to get your blood 3, 4, 5 times because you've used intravenously and you have a lot of sort of damaged veins. Patients know which veins work well. Like literally patients, because patients are always getting labs during pregnancy. And so I just say, hey, just tell them which vein works well. If you know one vein doesn't work, just tell them that. Just listen to them, respect them on that. And then really try to bundle the labs as much as you can, particularly if people find it triggering. Again, not everybody does, but some people find it very triggering. So if you have to, draw as infrequently as you can to some extent, so make sure you get all the labs ordered that you think you're going to need. and do them together if you can. The dose of MOUD should be continued during delivery, but it does not provide adequate pain relief. Really important to talk to your patients about that. Non-opioids can work really well, so you can use other things, muscle relaxants, ibuprofen. Some people use gabapentin. Short-acting opioids can also be added, probably at a higher, more frequent dose. Providers sometimes fear giving too much medication because they're worried that they're somehow going to either make them feel high, which won't happen, or they're worried they're going to oversedate them. But by far the greatest risk is self-directed discharge due to unmanaged pain. So if the patient says they have pain, give them the pain medication they need, and make sure you're not judging them as they've asked for pain meds. It can be complicated. Epidurals are often ideal, but be aware that most have fentanyl. So that's a really, really important issue. So, and it can be confusing. So it's really important to obtain neurotoxicology before the epidural. So I tell all my patients when they show up to the inpatient unit, like the first thing you say is, I need to leave you a urine before you give me anything. And like, I tell them that 3, 4, 5 times during the course of the pregnancy, like leave a urine the second you walk through the door, because that has proven to be like a game changer. I've had people who, their babies tested positive for fentanyl, and, but for that urine prior to the epidural, there would have been this question of like, well, is it her, fentanyl or not? Was she using before she came in? And so I think it's really important to do that. Sorry, my throat's dry. Methadone should be continued postpartum. The risk of severe oversedation is largely theoretical. There's usually a small dose decrease, but the mean dose was only about 3.7 milligrams over 12 weeks after birth. Treatment disengagement certainly is common, especially if the child was removed from custody. So the highest risk people, I think by far, are the people that go in and deliver a baby and they do not go home with their baby. It's a hugely high risk situation. So an overdose is a leading cause of death, of pregnancy-related deaths in the first year postpartum, especially kind of in that late postpartum period of sort of 9 to 12 months, and particularly if the patient has lost custody. Naloxone should be universally provided, ideally handed out or dispensed rather than prescribed, because people don't always pick it up or the pharmacy doesn't always fill it. Everybody should have it, but hugely high risk. Breastfeeding is recommended for women on methadone if there are no other contraindications. So ongoing illicit substance use, HIV. Hepatitis C is not a contraindication. A lot of confusion around that. So as long as the nipples are not cracked or bleeding, they can absolutely breastfeed if they have hepatitis C. It does appear to decrease NOWs, but it seems like it's probably kind of the active breastfeeding, like the skin-to-skin contact, the sort of swaddling and cuddling, because the amount of methadone in the breast milk is probably pretty insignificant. There is sort of this theoretical risk of rebound withdrawal if the breastfeeding is sort of abruptly stopped, but it doesn't seem to be reported in any kind of meaningful way. Gradual weaning works fine. Co-occurring mental health disorders, extremely common. I think probably most people have both the substance use disorder and the mental health disorder. Sometimes prescribers stop the meds cold turkey. Sometimes patients do. Sometimes things are worsened postpartum. I've had several situations of people who had really worsening psychiatric symptoms, probably because of the sleep deprivation around birth. And so just monitoring for that and awareness of that. Sometimes when people stop, I've had more people than I can count, say, I was using heroin or dope to monitor or to manage my bipolar disorder. So when I stop using those substances, their bipolar disorder might get worse. This is a really nice website that I like that has good information about best medications to use in pregnancy. Polysubstance use is common. That's beyond the scope of this lecture, but screening for stimulants, alcohol, cannabis, and nicotine. Peer support, hugely important. I don't now know how I ever practice without peers. They are so important. We have a co-located peer within our mom program who's amazing. Patients love her. She can see people in the community. She was talking to one of our patients last week who was really struggling not to use, and she just being able to sort of work with a patient having walked in their shoes is so tremendously valuable, and just she's a critical member of our team. And it's also important to discuss safe sleep with your patients with opiate use disorder. Co-sleeping is a pretty high risk for an adverse event, particularly in folks with a history of substance use disorder. So just making sure that it's fine if the infant's sleeping near the parents or near the bed, but in a bassinet rather than co-sleeping. And again, if there's cannabis and other things that people are using, it's just important to be aware that can increase your risk of having a sudden unexplained infant death. Main mom, Love Main Mom, part of Main Mom, have the largest program in Portland. It provides comprehensive care, including MOUD, counseling, peer support, obstetrical care. Patients don't have to be on MOUD to be a part of the program, nor do we have to be the prescriber. So methadone's a great example, right? We have plenty of patients who are enrolled with us who come. They get the sort of co-located obstetric care. We work with them on all the social determinants of health. I mean, there's so many other things. We might manage their psychiatric symptoms. Just be that go-between for all the other issues that might come up. The comprehensive care coordination really is the benefit of Main Mom, hands down. So this is my team that arranges transportation. It works with child welfare. We attend a ton of family team meetings. So the patient has had their child removed and they're sort of in that reunification process. We go all the time. We appear in court a lot too. But we try to go to family team meetings so that like we can really advocate for our patients. Like, yeah, they're doing well. They're engaged in treatment. They're coming in. Their urines are appropriate. Coordinating with PCPs, other specialists. So if somebody needs a psychiatric referral, somebody needs to follow up on some issue that presented itself, we can certainly connect folks with that. WIC, food resources, med storage bags, all kinds of stuff. So there's a Main Mom website. There's a really nice Main Mom video. It's about 5 minutes long that talks about the program that's linked there. I think that's my last slide. And I apologize for all the stop sharing. I apologize for all the challenges with the slides coming up and down.
Thank you so much. We have one question so far, just asking the length of time for a baby to experience withdrawals.
Yeah, so it's a common question, and full disclosure, I'm not a pediatrician or a pediatric specialist. I think most babies are in and out of the hospital within 5 days if there's not any other complications or if their withdrawal is not, meaningful in terms of like requiring a lot of medication and management. I think there is some evidence that, it lasts for a longer period than that. So sometimes people are the infants are maybe a little bit more irritable. I mean, there is this sort of period of time where I think there is some withdrawal happening that's probably lower in terms of an acuity. And so just important to make sure patients are, feel like they have good resources, good supports, that they have someone they can lean on. Because having an irritable baby can be stressful, right? So making sure that you have people that can help provide. I went to visit a patient, the one that I saw in the hotel the other day. When I was out with the fire department, I see patients in the community, and just seeing a friend in her room, just kind of cuddling the infant when mom was really overwhelmed. I mean, just that sort of support. And then the fatigue, if the infant doesn't sleep very well, making sure again that there's not the co-sleeping, and then if there is breastfeeding that's happening overnight, to make sure that there's a plan so that the infant doesn't get smothered, because it's not uncommon to fall asleep when infants are breastfeeding. So just making sure that you have a plan for all those things.
All right, the next question is, how long should mom be split dosing methadone after delivering a baby?
Oh, that's a good question. I feel like pretty quickly they go back to regular daily dosing. My experience has been that they split it in the hospital, and then usually one of the first visits back to see that. That's something that the outpatient treatment program would do, but they usually switch it back. Not immediately necessarily, but I usually see within like the first month, people have switched back to a single daily dose. Depends on how quickly they see the doctor, and sometimes like the doctors can like put a hold on a patient so that like when the patient comes into dose, they would have that appointment with the doctor. Sometimes that doesn't happen. Sometimes it's just kind of a standard follow-up, but it's usually pretty quickly. I think the metabolism changes pretty quickly postpartum.
Awesome, thank you. I'm not seeing any more questions.
The slides are available, and I actually believe I remember to put my email on the slide, which is also something I'm not very good at. And so certainly if something comes up after, or you want, I did have a whole list of references there too. So if there's a particular study that you're wondering kind of where I got that information from, the references are there. And certainly feel free to email me if there's a question you think of after, or anything like that. That's totally fine. And thanks for your patience again with the slide challenges.
Thank you so much. We really appreciate you being here. And Ryan did just put the evaluation link in the chat for everyone. So if you don't mind filling that out. Oh, we have one more question before we close out. any specific nutrition guidance for pregnant participants in treatment?
That's a good question. Actually, somebody else asked me that not too long ago. I mean, I guess I don't know of any in terms of, I guess I just think of adequate nutrition. I don't, that's sort of the space we're sitting in a lot is, making sure that people are connected to WIC and are connected to other resources. We hand out a ton of food bags and just an understanding of what people have access to. Some people who are unhoused or unsheltered may have access to refrigeration, but not a way to heat food. They might have access to a way to heat food, but not refrigeration. So really trying to understand what your patients have access to or don't have access to and trying to meet their needs. But, I think adequate nutrition as much as possible, balanced nutrition as much as possible, and just, an awareness of all the social determinants of health is really key.
Awesome. Thank you so much. Really appreciate you being here.
Thanks everybody for coming.
Ryan, real quick, will the evaluation also be sent through email?
Yes, once I have the recording, I'll edit it and upload it and share that with the links and slides and evaluation as soon as I can.
All right, perfect. Thank you, everyone.
Thank you all. Have a great afternoon.
Bye.